Hello everybody, welcome to another video. So in today's video we'll be looking at a new topic known as trigeminal neuralgia. So trigeminal neuralgia sometimes is also known as tic douloureux. So basically this trigeminal neuralgia, it's basically known as like a condition where a person experiences sudden severe facial pain, often described as like electric shock, or like a stabbing pain. So it primarily affects the trigeminal nerve, which is usually responsible for sending sensation from the face to the brain. So that's why it's known as trigeminal neuralgia. So even in this condition, even mild stimulation like touch, chewing, talking, or brushing the teeth can trigger like an intense episode of pain. So it is chronic, guys. It is a long-lasting condition, but the condition can be managed with medications or in severe cases with surgery. So looking at the background of this trigeminal neuralgia, so it's usually most common in people over the age of 50, but it can usually occur at any age, but it's just more commonly seen in people around the age of 50. So women are generally more affected than men, and it can seriously affect the person's quality of life, causing like fear of eating, talking, or even touching the person's face. So pain episodes, they come and go, which is known as like remission and relapse. So let's look at the anatomy and the physiology of the trigeminal nerve. What's the trigeminal nerve? So the trigeminal nerve is basically the fifth cranial nerve, and it is the main sensory nerve of the face. So the trigeminal nerve has three major branches: the ophthalmic, that is the forehead, the eyes, and the upper nose; then the maxillary, that is the cheeks, the upper lip, and the upper teeth; then the mandibular, that is the lower jaw, the lower teeth, part of the tongue, and the chewing muscle. So each side of the face has its own trigeminal nerve. So trigeminal neuralgia usually affects one side, so it is unilateral, and it most often involves the maxillary and the mandibular. So what exactly causes trigeminal neuralgia? So trigeminal neuralgia happens when the trigeminal nerve is irritated or compressed, and this causes the nerve to like misfire and send pain signals unnecessarily, like pain signals that are not even needed at that certain point. So one of the causes is known as vascular compression, and is basically when a blood vessel, usually an artery, presses on the nerve near its roots, wearing away the myelin sheaths and causing misfiring. So this is generally the most common cause of trigeminal neuralgia. And then we also have multiple sclerosis. So multiple sclerosis is an autoimmune disease that damages the myelin around the nerves. So it damages the myelin around the nerves. And then another cause is like tumors too. So tumors is like a rare cause of this trigeminal neuralgia, but it is also part of the causes. So a tumor pressing the nerve can cause the symptoms of this condition. Then trauma to like facial or dental surgery, or having an injury near that particular nerve, can lead to like the symptoms. Then sometimes it can be idiopathic, like sometimes there is no exact cause of this trigeminal neuralgia, it just happens. So the major cause is that vascular compression, where a blood vessel presses on the nerve, and then it causes the whole misfiring and everything. So looking at the pathophysiology, so the trigeminal nerve, it becomes hyperactive due to demyelination, which is like the loss of the protective myelin covering. So this makes it more likely to overreact to normal stimuli like touch, movement, and it will now cause like this intense pain that was not even needed at first. Then imagine it like a naked electrical wire that any small touch or friction can like spark a touch, so like can spark a shock, sorry. So imagine it like that. So it's hyperactive due to this demyelination, sorry. So that is basically it. So looking at the signs and symptoms, number one, there will be a severe facial pain, like it will be sharp, stabbing, electric shock like, and to be on one side of the face. Then the attacks will also be brief, like they can last like seconds to minutes, but they may occur many times in a day, but they are very short. And then triggers like just like the trigger is usually very mild, like just like even a light touch or talking or chewing. So all these things like you do in your normal everyday life will trigger this severe pain. Then there's also the fact that, okay, I've said this before, the fact that it's only one-sided and only one side of the face is usually affected. Then it has like a refractory period, so after an attack there's often a short time where the pain won't occur, like a break basically. Then with this condition there's also no sensory loss, so touch sensation is usually normal like between the attacks. Looking at the differential diagnosis, like how we can differentiate other conditions from this trigeminal neuralgia. So usually when someone has like a facial pain, so if this pain is like constant, if it's like a constant dull ache and is localized to a tooth, so we would assume this is like coming from the teeth, like is it dental pain. Then if the pain comes with headache, nausea, visual symptoms, it could be a migraine. Then if the pain is like behind one eye and it comes with tearing, nasal congestion, then these are classic signs of cluster headache. Then there's also something known as post hepatic neuralgia, and it usually occurs like after shingles. So there's usually a burning pain in the dermatome. So basically all these other conditions, they come with pain that are like similar to the pain seen in trigeminal neuralgia, but they have like these distinguishing features. So how is this condition diagnosed? So for the clinical diagnosis is based on like based on the history and the pain pattern, and then MRIs can be done to rule out conditions like tumor or multiple sclerosis or vascular compression that could be causing the condition. So for the treatment, the first line treatment, like the first line medications that are given for this condition, we give carbamazepine, and it is basically an anticonvulsant that stabilizes nerve signals. So while we're giving it, we have to monitor for like the liver function and also the blood counts. Then we can give oxcarbazepine, and this is basically similar to carbamazepine, but it usually comes with fewer side effects. Then also gabapentin, pregabalin, they are nerve pain modulators, so they can also help as like first line treatments. And then baclofen can be given too, because baclofen is a muscle relaxant, and it may help in this condition when combined with other medications. Then sometimes antidepressants are helpful too, like tricyclic antidepressants like amitriptyline is also helpful in certain cases. So most of the drugs used for this condition, they are either anti-epileptics or neuromodulators, and they basically reduce abnormal nerve firing. So we use either anti-epileptics or neuromodulators for this condition as like the first line treatment. So usually if medications fail, we have to like opt for surgery. So some surgeries that are done in this case, like for example, there's macrovascular decompression, which is best for long-term relief. And basically here a neurosurgeon moves the blood vessel that is causing the compression of the nerve and pads it. So it's one of the surgical interventions in this case. And then we also have something called radiofrequency ablation, which is when they selectively damage the particular nerve to stop the pain. So they selectively damage the trigeminal nerve to stop the pain. And then we also have gamma knife radio surgery, which is like a focused radiation to reduce the nerve function. Then there's also glycerol injection too, which chemically damages like part of the nerve that is causing the pain. So these are like surgery options that can be done if medications are not effective. So basically management tips, so it's good to start with a low dose of carbamazepine and then titrate it gradually. Then when we're giving these anti-epileptics or neuromodulators, we have to monitor for side effects like dizziness, nausea, all those things. Then we also have to educate patients about like triggers and how they can specifically avoid what exactly is triggering them. And then we should also refer to like neurology for evaluation and follow up of the case if the diagnosis is unclear, or if like the first line treatment fails. So in summary for this trigeminal neuralgia, so the type of pain, how's the type of pain? Is sharp, is like an electric shock, and is stabbing. The duration, seconds to minutes. The one side of the face, and it's usually that means it's unilateral. Then the triggers, like a light touch, even the wind can trigger it. Chewing, talking, all these things can trigger it. What's the first line drug? The first line drug is carbamazepine. And what surgical interventions can be done? Microvascular decompression or ablation. So there's one patient education I saw online, and it's basically known as layperson talk. And what this layperson talk basically states is that you have a nerve in your face that acts like a live wire. So it sends pain signals when it shouldn't, and it causes sudden attacks of sharp pain, and it feels like an electric shock. So with the right medicines, we can calm the nerve down and reduce these painful attacks. So this is like a straightforward way of explaining it to a patient, that okay, you have a nerve in your face that is acting like a live wire, and we can basically give the right medicines to help to reduce to calm the nerve down, the nerve that is acting like a live wire, and reduce its misfiring and all those things. So that is basically the breakdown of this topic known as trigeminal neuralgia. I enjoyed this topic. I enjoyed learning about this topic, and I hope you enjoyed learning about it too. So see you in the next video. Bye.